Hi, I'm Dr. Seth Force. I am the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University Hospital in Atlanta, Georgia. The short answer is really any stage can be appropriate for surgery, but that answer becomes a lot more complicated when we're talking about advanced stage lung cancer. So we separate lung cancer into early stage, which would include stage 1 and stage 2 cancer, and advanced stage, which is stage 3 and stage 4. And the prognosis for lung cancer, like any cancer, is worse as you get more advanced stage cancer. So stage 1 cancer is typically a cancer that's confined to a lesion in some area of the lung, and there's no evidence of any spread. And it's also typically a smaller lesion, a lesion that is less than 5 centimeters, which is about 2 inches. As tumors get larger, get over 5 centimeters and even over 7 or 8 centimeters, then the stage goes up to stage 2 and then stage 3. As tumors spread to lymph nodes that are buried into the lobe of the lung where the cancer is, that can represent a stage 2 cancer. And as cancer spread to lymph nodes in the middle of the chest surrounding the main windpipe or trachea, that can be stage 3. And then when you get cancers that spread to other organs, that's stage 4. So the standard treatment for patients who are diagnosed with stage 1 or stage 2 lung cancer is surgery. That's the recommended treatment for those patients. And typically that would involve removing the entire lobe where the cancer is. There are some caveats to that where we can remove less than a lobe for smaller lesions, particularly nodules that are under 2 centimeters. We can remove less than a lobe. Patients who have stage 2 cancer, the standard treatment is surgery followed by chemotherapy. So that's just the standard treatment. For patients who are not candidates for surgery, it may be the best treatment, but they may have too many medical comorbidities. Surgery may be too risky. That's where we start talking about doing stereotactic radiation or localized radiation, and I'm sure that's probably a topic for a different discussion. But there are options for patients who cannot tolerate surgery. It's not surgery or nothing. Stage 3 lung cancer is a little bit more controversial because the studies that are out there not all of them show that surgery provides a benefit to patients from a survival standpoint over standard chemotherapy and radiation alone. However, there are some caveats to that. So for patients who have an isolated area of lymph node spread and that lymph node is not very enlarged, that's making them a stage 3 lung cancer, we will often treat them with chemotherapy or chemotherapy and radiation. And then if it looks like they have been downstage, meaning that we've cleared the lymph nodes, then we will move on and operate. And there are some studies suggesting that doing surgery in that setting, so giving what we call neoadjuvant therapy, which is chemotherapy with or without radiation prior to surgery and then operating, provides a survival advantage in that select group of patients. By the same token, there are some patients with stage 4 cancer who we will operate on. These are typically patients with isolated brain metastases, and it's often that the brain metastasis presents first. So someone has a neurologic deficit, they have urgent or emergent brain surgery to remove what looks like a cancer, and then it turns out it's a lung cancer, and then we do the imaging and we see the lung lesion. In some of these patients, they have no other evidence of any metastasis, and those patients will move on to get chemotherapy. And once they finish chemotherapy and we repeat their staging, their scans, and we see no other evidence of spread, we will often operate on those patients and remove the cancer. To a lesser degree, that's also true with metastasis to the adrenal glands. So the adrenal glands are glands that sit on top of the kidneys that control steroid secretions. And if you have an isolated adrenal metastasis, in certain situations, we will operate and remove the lung cancer in the same setting where the patients get the adrenal lesion removed, either sometimes before we take out the lung cancer, sometimes at the same time, but they all get chemotherapy first. The results of doing lung resections after removal of isolated adrenal metastasis, those results are not as good as for isolated brain metastasis. And I just want to point out those are very, very rare isolated situations. That is not a very common presentation where people present with isolated metastases. But those are the settings where we would operate on more advanced stage cancers.